Hi everyone, this is Dr. Fox. Let's talk about the fascial spaces of the face. In this video, we'll discuss the most clinically relevant fascial spaces of the face. So let's start with our favorite buccolabial muscles. So we have levator labii superioris aliquinosi, levator labii superioris, zygomaticus minor and major, and in total, those four muscles are sometimes referred to as the quadratus labii muscle. So quadratus labii means the four muscles of the lip. Deep to those four muscles is a space which we can see here. And that space is known as the infraorbital or canine fascial space. Anatomists refer to this as the infraorbital space. Clinicians refer to it as the canine space. Now, running through this space will be the infraorbital nerve. So this is a branch of the maxillary division of the trigeminal nerve, or V2. This is the terminal branch of that. We also have the facial artery and vein ascending and descending through this space. And it's into this space that any odontogenic infections of the maxillary incisors, canines, or first premolars will drain. Anything beyond the first premolar is going to drain into the buccal space. The infraorbital and the buccal spaces are contiguous with one another. So anything can move freely between these two spaces. So let's take a look at that buccal fascial space. It's very obvious in your donor. It's kind of bounded posteriorly there by the masseter muscle. We can see the zygomatic bone is the roof to that. It will go down to the mandible. A couple of notable things are traveling through that, including the parotid or Stenson's duct and the buccal branch of the mandibular nerve, or the buccal branch of V3, which is a sensory nerve. And we also usually have a buccal fat pad in there as well. So there's a lot happening in this space. We can have odontogenic infections from maxillary second premolars as well as molars drain into this space, and we could have materials move from the infraorbital space into this space. We also have two other fascial spaces that we don't give a lot of airtime to in this course, but are probably worthy of mentioning. And they include the submasseteric, or just masseteric space, and the pterygomandibular space. Now, to understand these spaces, we need to talk a little bit more about the MSK of the jaw. So we've got the mandible coming down like so. It would be deep here. Let's draw this properly. You can't see it because it's going to be deep to the masseter. So it's coming down like so. And the masseter is in the way, so we can't see that. So looking at it more in profile, let's say that this is the mandible, so the bone one, and then we have the masseter running over it. So the masseter, and this is the muscle because both are M's. Between the masseter and the mandible is the submasseteric space. Now, even deeper than the mandible here, or the ramus of the mandible if you want to get really specific about it, is another muscle called the medial pterygoid. It sort of mirrors the masseter. So the two of these muscles really have the mandible in a sling. Now, deep to the ramus of the mandible, but superficial to the medial pterygoid muscle, we have the pterygomandibular space. And so materials may drain from the buccal space posteriorly into either the submasseteric or the pterygomandibular spaces. Now, those spaces are contiguous with the lateral pharyngeal space, which is even deeper. So if you kind of imagine a pyramid, let's see what we can see here. So this is part of the buccinator muscle. It's been cut. There is the pterygomandibular raphe. This is the superior pharyngeal constrictor muscle. There's the middle pharyngeal constrictor muscle. The inferior one is there. So that's the middle, and that's the superior, whereas that's buccinator. If we think of an inverted pyramid, kind of going from the base of the skull down toward the hyoid bone, back up, just superficial to that superior and middle pharyngeal constrictor muscle, that is the lateral pharyngeal space. We can see there's the styloid process of the temporal bone, and there's stylohyoid connecting that. But this space is sort of a key space because not only can you enter it from the submasseteric space or the pterygomandibular space, but it's also contiguous with that retropharyngeal space. So retropharyngeal space is behind the pharynx. Lateral pharyngeal space is lateral to the pharynx. And it's that retropharyngeal space that, as you recall, can be divided into the true retropharyngeal space, which is posterior to the buccopharyngeal fascia and anterior to the alar fascia, that kind of peters out around like C4, C6-ish. And then there's the danger space, which is between the alar fascia anteriorly and the prevertebral fascia posteriorly, that is the conduit down to the mediastinum where the heart lives. So I've outlined some of the cranial pathways here in kind of a lighter green or turquoise here. So we can see kind of operationally materials can move if there's an infection into that infraorbital space, down through the buccal space, back into the submasseteric space. So this is just this pathway here. They can also move into the pterygomandibular space, to the lateral pharyngeal space, and into the retropharyngeal space. Now, in subsequent sessions, when we talk about the oral cavity, we'll mention the sublingual spaces and the submandibular spaces. These are spaces down here more associated with the mandible. The sublingual space can drain into the submandibular space and vice versa. Either of them can drain back into the lateral pharyngeal space. Now, these are spaces that you'll discuss in greater detail with the risk of something known as Ludwig's angina. Angina means to strangle. So you might have heard of someone like having angina. That references chest pains that are the result of some of the vasculature that serves the heart. So the coronary arteries or their branches being occluded, and therefore an individual experiences chest pain or angina. Ludwig's angina is the result of cellulitis, so generally a bacterial infection, but not necessarily, that invades these spaces. And when it does, the swelling or the edema really forces the airway closed. So this is a life-threatening condition. It's not all that common, especially now in the age of antibiotics, but it is a reason why dentists are so very crucial in evaluating perioral swellings so that they can be addressed in a timely manner. So that leads us to our assessment question, and that is, an odontogenic infection from a maxillary canine may immediately invade which fascial space? Well, let's just go through and cross out the ones that we know can't be. It's not going to be a lateral pharyngeal, it's not going to be a retropharyngeal, it's not going to be a submesenteric. So that leaves buccal and infraorbital or canine space. That canine is the big old green flag there that suggests to me that this is the right answer. Know this, we don't ask trick questions here. If you think that there's something in it that's a clue, it's probably a clue. But with respect to maxillary odontogenic infections, recall that it is the first premolar, which is the last tooth that drains into that space. So second premolar all the way through the molars are going to drain into the buccal space. So correct answer B, infraorbital or canine space. Final answer. All right, all. Thank you so much for your time.